Welcome everyone to the Journal of the American Society of Echocardiography podcast. My name is Dr. Amr Johri, and it's a great pleasure to have this special podcast happening today. This is the first time we've done the podcast live, so I'm very excited. And this is also the very first time that we're doing this special collaboration with the Canadian Society of Echocardiography. So the CSE has been doing these live virtual journal clubs, and the JASE has been doing pre-recorded podcasts. So I thought it'd be a great idea to combine our efforts today. And in fact, we have sort of a mashup going on today between the Canadian Society of Echocardiography live journal club and the JASE podcast. So it's a great pleasure for you guys to participate in this experiment. You're going to meet my co-host today, Dr. Michael Tsang, who's an assistant professor at UBC. And we have a wonderful panel of experts and speakers today. We're going to be talking about the article entitled Normal Values of Cardiac Output and Stroke Volume According to Measurement Technique, Age, Sex, and Ethnicity. Results of the World Alliances of Societies of Echo Study. And this article appears in the October 2021 issue, volume 34, issue 10 of the journal. It's also available online, and it's by Dr. Patel and his colleagues. So firstly, it's a wonderful pleasure to have Dr. Michael Picard here. Dr. Picard has been a mentor for me for many, many years. So Mike, thank you so much for joining us today.
Pleasure to be here.
Thanks, Mike. It's been quite a year for the journal, hasn't it? With the pandemic and all the guidelines, you've been working at full bore.
Oh, the last 2 years have been very busy. I think with everyone at home, they've been able to write a lot more papers or finish up projects that they hadn't finished. And so we've seen a lot more submissions and papers, and that's great for the journal. The quality of the papers continue to rise. Unfortunately, with more submissions, it also means that our rejection rate goes a bit higher, which is always a disappointment for
yes,
our authors.
Yeah. What's been the highlight of the year for you?
Oh, well, actually, it's a general comment. I mean, I just get to learn so much from reading all the papers that come in to the journal on a lot of various topics. And some are topics I'm familiar with, but many are just cutting edge areas that I'm a novice in. And so I've been able to really keep my fingers on the pulse of research in echocardiography. And it's also been great to get to interact with our international members who function as reviewers and authors and editorial writers. So it's a great fellowship.
And I certainly appreciate your willingness to support the JASE podcast and the creativity and all the different things we try. So that's been a lot of fun for people to access the literature in another way. So we really appreciate that and your sort of vision for the podcast. So thank you very much.
Well, thank you for doing it. And this one today, I think it's a neat experiment. I hope it works, and I hope you continue to do this. We're happy to get people from CSE involved, both in this podcast, or if all of you have any ideas on content, review paper topics that might benefit from review papers or other types of things. Also, make use of the JASE social media, the podcasts, and other non-traditional modes of communication. I'm always happy to hear any thoughts you have about that. So you can always contact me through the JASE website. The email notifications are all there. You can notify me or the managing editor. Happy to have a dialogue about any thoughts you have about what else we should do for all of you.
That's amazing. So for today's paper, it's from the WAZE study. And we've actually had podcasts previously on papers that are coming out of this very important international alliance. And so I think, there is some people that may not be familiar with WAZE. So before we get into the paper, I thought it'd be great if we look at what WAZE exactly is. And so I'm going to get Dr. Picard to tell us a little bit about WAZE. I'm going to share my slides here. And Dr. Picard, can you tell us about this overall program before we get into the specific paper?
Sure. So the first disclosure is that I have nothing to do with the WAZE study. I guess I'm here more as someone who's read a lot of their work and am familiar with it. So WAZE stands for the World Alliance Societies of Echocardiography. And the goal here, actually, why don't you go to the next slide? You know, we use echocardiography in a lot of different ways, but particularly we're always identifying pathologic states. We're trying to differentiate abnormalities from normal. And in this slide, obviously, everyone can see this echo with this big tumor. I assume this is a LA myxoma. And it's obviously very easy to look at that echo and say that what's abnormal here. But, you know, a big piece of what we do in echocardiography is we measure cardiac structures. And obviously, to identify what's abnormal, we have to know what's normal. And most of the data that defines the normal values for various cardiac structures come from very select audiences. Most of it, here's a table from the ASC guidelines on chamber quantification. And all of these normal values come from either European or US studies. And so it's a very select group in terms of race, ethnicity. We hopefully have a good sex balance. But when you look at a variety of studies from around the world, you can see that there are differences in some of the parameters that we typically measure, like the LV, aortic root, and left atrium. So, you know, if you're looking at a Chinese population, you may have very different normal values than you might from a population from Italy or from British Columbia or whatever. And so the WAZE study was proposed by Federico Ash and Roberta Lang, and they actually received funding from the ASC to do this study, which is really an opportunity. It's almost like a registry. They've collected echocardiograms on normal patients from around the world in the hopes that a better normal value set can be collected based on a much wider population with a variety of different characteristics. So as you can see here, study aims are listed. They're collecting normal values in a large cohort of multinational, multi-race subjects. They're looking at a variety of different parameters: LV, RV, atrial size and function. They are, today we're going to talk about some Doppler parameters. They've even collected data on COVID patients and the changes in cardiac morphology with COVID infection across the world. So if we go to the next slide, basically they've enrolled from 19 centers. You can see the map here in blue are the sites from around the world. And every center enrolls 100 healthy patients across age from greater than 18 to as old as they can get, as long as the patients are healthy. They have to be free of hypertension. They have to have a BMI under 30 and limited valve disease or just mild valve disease. So you can imagine as you get into the older patients above 65 and 70, it's hard to find patients who aren't hypertensive or who have significant valve disease or some other factors that may affect their cardiac function. So I would say that most of the patients are in that sort of 18 to 65 age range. And all of the patients get an echocardiogram. The data are sent to a core lab and the measurements are made. And then they've been generating lots of papers, and we're going to hear about one of them today.
That's wonderful. Thank you so much, Mike, for giving us that high level perspective. Do you see that, you know, at someday we'll have many different normal values pasted on the wall in our echo labs? Is that sort of where we might be thinking about, or maybe some sort of integration with AI to sort through some of these nuances and differences?
Yeah, I imagine that we're going to make use of AI in this regard. And I think that if you profile your patient, it's going to be obviously sex, age and ethnicity and race, and those may put you into a specific table with normal values for that particular type of patient. So I think this is an ideal place where we can use computer learning to really do a lot of the stratification for us. But it's an interesting factor. The other interesting thing that we probably won't talk about today is obesity. And so although there are certain ethnic groups that traditionally may have a relatively small body size and maybe shorter stature and maybe skinnier compared to some of the US people that I deal with, even in some of those populations, obesity has become an issue. And so, how is that going to affect the normal values that we obtain in some of those different populations? And I think that's still something that's going to get sorted out. And also the other thing to consider, if we index some of these measures like we do for the left atrium and the aortic root, how do you index and what's the best measured index? We typically use BSA, but again, as our population is getting heavier, that probably is not the right parameter to be using. So that's one of the other issues. I don't think WAZE will be able to address that since they have a very narrow recruitment aim, but that's something that we need to also think about in the future.
That's wonderful, Mike, giving us your thoughts on that, and certainly points to some more interesting research directions that I think might be of interest to the journal. So that's good to know. Thank you. So thanks so much for your time, Mike. What we're going to do is hand it over to Michael Tsang. Dr. Tsang, if you can take over with respect to the paper that we're going to talk about today. Thank you.
Thank you, Dr. Johri. So it's Michael Tsang from Vancouver. It's my great pleasure and privilege to introduce the presenters of today's Journal Club, Dr. Sabe and Dr. Sarah Blissett, as well as our expert panelists, Dr. Annabelle Chantonu and Dr. Hanan Ben-Barkat. To give you some introduction about these speakers, so Dr. Sarah Blissett is an assistant professor of medicine and center researcher at the Center for Education Research and Innovation at Western University. Dr. Blissett's clinical work focuses on cardiac imaging, adult congenital heart disease, and cardio-obstetrics. Her academic interests are focused on improving education in cardiology, particularly in optimizing learning in workplace learning environments. Dr. Sabe joined the Division of Cardiology at London Health Sciences Centre in 2016 and is currently an Associate Professor of Medicine. Dr. D currently serves as the Director of Echo for the London Health Sciences Centre. He's also the Fellowship Director for Adult Echo and the Educational Director for the Division of Cardiology. His current clinical interests include echocardiography, heart failure, and transplantation. And for our expert panelists, we've got Dr. Annabelle Chantonu, who is an echocardiographer at the Jewish General Hospital of McGill University, where she was previously the cardiology program co-director. She completed her echo fellowship at the Massachusetts General Hospital under Dr. Picard. And Dr. Hanan Ben-Barkat is an echocardiographer at L'Hôpital Maisonneuve Rosemont, which is a hospital affiliated with the University of Montreal. She completed her cardiology training at McGill and echo fellowship at Queen's University with Dr. Johri. Thank you very much, everyone, and we look forward to your presentation. And for the audience, if there are any questions, feel free to enter that in the chat box, please.
Okay, so I'm going to take it away. Thank you for that great introduction, Michael, and thank you, Amr, for your organization, and special thanks to Dr. Picard for that great segue with WAZE, and thanks to all my friends and colleagues that I see across from coast to coast on the call. It's really nice to participate in this along with my colleague, Dr. Sarah Blissett. We're actually in the same room together, so we'll be presenting this together, and I'll be passing it over to her very shortly. So the first question is, why was this paper of interest to us? We had free reign to pick anything from the October journal, JASE edition. And as Michael had said, I'm also a heart failure physician. And, there's long been debated in terms of the utility of echo regarding the hemodynamic assessment and the knowledge that we get from echocardiography and how this helps clinical assessment, particularly with stroke volume index. As Dr. Picard nicely outlined, with respect to gender and ethnic variability, well, we know that that's of particular interest and importance in aspects of cardiac structure, i.e. end diastolic volume, hypertrophy, But when we look at stroke volume, even though it's a subtraction of the end systolic volume from the end diastolic volume, it is more of a marker of cardiac function. And the fact that this may have gender or ethnic variability is something of interest. Another interesting thing about the paper is that it compares traditional versus contemporary ways of assessing stroke volume. What do I mean by that? Well, we're taking the old workhorse, which is pulse wave Doppler across the LVOT, and we're comparing it to 3D and 2D. And the original paper from 1996 was comparing stroke volume from the LVOT to cath data. So I think it's really a nice contemporary wrap up of how things go. And I think also another point that I didn't mention here is just, as a lab director or somebody who works in a very high volume lab here in London, it's important to see what the variability can be and what normal truly is, as Dr. Picard had pointed out. A little bit of the segue, there's a whole bunch of great review papers in terms of background reading for hemodynamics and echocardiography. And you can see in a paper like this, they take patients with half REF and half PEF, so REF being an EF of less than 40%, PEF being above 50%. And all that number really tells us is it's a marker for how we're going to treat that patient with our goal-directed medical therapy if they have half REF. But if we can prove that the patient also has a low flow state, as this one example shows, it might give us a little more clinical importance. Where might this apply? Well, this is a patient of mine. He's 42 years old. He's got familial TTR amyloid. You can see there is LV dysfunction. His EF is about 35%. But, probably preceding this drop, if you look at patients with TTR amyloid, you'll see that they have a low stroke volume index. And that's part of the reason that a lot of these patients account for what we see in low gradient, paradoxical, low flow, low gradient aortic stenosis. So this is an example where if you have PEF or have REF, the stroke volume index may help you in terms of seeing how sick the patient is. Paradoxical low flow, low gradient aortic stenosis, stage D3 in the most up-to-date valvular guidelines. This is a patient in London. The EF is preserved, and you can see that the peak velocity is 2.9. The gradients aren't quite in the severe range. The valve area is 0.59 centimeters squared, and the stroke volume index is 17.4 mils per meter squared. So this is paradoxical low flow, low gradient aortic stenosis, probably where we use stroke volume and stroke volume index the most within our own contemporary lab right now. And recent papers have suggested maybe we should be using a slightly different gender-based cutoff of 42 mils per meter squared for males and 32 mils per meter squared for females. So the background on this paper, the assessment of cardiac output and stroke volume, it is important for a couple of reasons that I've shown. Including differentiating low versus high output heart failure. High output heart failure, typically an index of above 3.5. Identifying low flow, low gradient aortic stenosis, optimization of hemodynamically unstable patients. This is of particular use in the POCUS world, where they often will look at Doppler stroke volumes, and phenotyping the hemodynamic presentation of cardiogenic shock. So a lot of my colleagues, we do a lot of right heart caths and invasive hemodynamics here in our heart failure service here in London. And generally speaking, invasive right heart catheterization has been considered the gold standard for cardiac output measurement. But it's not vastly available. There are procedural complications. Even within the technique itself, I was just talking to my colleague today, asking him his thoughts on this paper. And when they do a FIC cardiac output, cardiac index, there are a number of different formulas they can apply. There are individual patient settings that can affect the actual value derived. Echo, we know, is widely available. It's a non-invasive tool. It's our workhorse for cardiac structure and function. And studies have shown that Doppler, 2D, and 3D echo can correlate closely with invasive thermodilution and FIC methods. However, these reference values, whether or not there are differences, really was not known prior to this paper. And if we can use these interchangeably remains unclear, as well as I stated, the real crux of the WAZE study is looking at those differences in age, gender, and ethnicity that are becoming more and more apparent within cardiology. The study aims are very nicely laid out. It's to establish normative reference values for stroke volume and cardiac output using each of the available techniques, determine the influence of age, sex, and ethnicity on these measurements, and define cutoff values for low and high output states. As Dr. Picard has laid out, and I'm really pleased to see some of the study authors on the call. It is a multi-center international observational prospective cross-sectional study. They started with about 2008 patients, and then 558 had to be excluded because they didn't have a 3D volume set. This left a total of 1450 subjects, almost equal representation of men and women that formed the final population for the analysis of cardiac output and stroke volume. In terms of the echo image acquisition and analysis protocol, I don't want to spend too much time on this, but stroke volume was measured using 3 techniques using vendor-independent software, the first being Doppler. I'll show you an example on the next slide. And the second using 2D, as you would for Simpson's biplane. And the third using 3D LV analysis. And this was done using vendor-neutral software, the TomTech platform. Stroke volume index, as you know, is basically the stroke volume divided by the BSA. They also looked at it by height. Cardiac output is then the product of the stroke volume and the heart rate, and cardiac index is the cardiac output indexed by BSA and by height. So here's a really nice example of a patient that was involved within the WAZE study and the 3 different techniques. And these should be very, very common and familiar to most people's labs. But in short, the image on the left shows the Doppler assessment, where basically the LVOT is measured proximal to the aortic valve. A Doppler VTI is then taken at a sweep speed of 100. From there, the stroke volume is then calculated, and this gives us a value in mils. And that divided by the BSA gives us the stroke volume index. We do know that there are some issues with this regarding angle dependency, the usual Doppler issues surrounding this methodology, and that's all I'll say about that. The second image here shows a 2D assessment using the standard views for biplane Simpsons, apical 4 and apical 2 chamber, during which a trace is done, and diastole, as you know, is defined as when the ventricle is largest, and systole is when the ventricle is smallest. Those 2 values are subtracted, and we get our stroke volume. Stroke volume index is then that value divided by BSA. And then the third and final method is taking a complete volumetric set of the LV and using the vendor-neutral software to then generate a 3D assessment and assessing the end diastolic volume, the end systolic volume, and from there we calculate the stroke volume and the stroke volume index in a similar method. So you can see in this example there is a difference in the stroke volume index across the different methods of assessment. And each method has its own issues, the geometric assumptions that go into doing a Simpson's biplane, et cetera, et cetera. Okay, now without further ado, I'm now going to pass it over to my friend and colleague, Dr. Sarah Blissett, to continue on and take us through the results.
Hi, thank you so much for the great introduction and for the opportunity to present along with this great panel today about this impactful paper. So picking up where Dr. D left off, this study presents data on 1,450 participants with a mean age of 48, and 53% were males. As specified with the inclusion criteria, the average BSA was in the normal range at 1.78. And the average systolic and diastolic blood pressures were in the normal range as well, with 121 and 74 millimeters of mercury. In terms of race, Asian was the most common race included, and they defined that as individuals from China, Korea, Japan, Philippines, and India. 33% were identified as white, 13% as other, and 12% as Black. The authors first set out to identify normative values for stroke volume, cardiac output, and cardiac index. So I'll take you through the data that allowed them to come up with these normative ranges. I'll present each parameter based on each measurement technique. You can see here that the average stroke volume from 2D echo was 58 milliliters, and it was 73 by 3D echo with a Doppler estimate in between at 69. This trend persisted with indexation, with 2D echo having an average stroke volume index of 33 milliliters per meter squared, and 3D echo having an average BSA indexed stroke volume of 41 milliliters per meter squared. In terms of cardiac output, again, we see the similar trend with 2D echo having an estimate of 3.9 liters per minute, which is about 1 liter per minute lower than the average from 3D echo at 4.87 liters per minute. And this trend, again, persists with indexation. Taking a statistical lens on this data, we see that all 2D measurements were significantly lower than Doppler and 3D measurements. And furthermore, all Doppler measurements were significantly lower than 3D. Moving forward now to comparisons by sex, it's first important to note that females had smaller BSAs, higher heart rates, and smaller LVOT diameters, particularly in the context of how Dr. D reminded us that these parameters are calculated. Moving on to the data. So females, on average, had lower stroke volume and stroke volume index by all 3 methods. As a point of example, let's look at the 3D values. So the average stroke volume in women by 3D echo was 66 milliliters and 80 milliliters in men. When we index to BSA, the average for females was 40, and for males, it was 42. Moving on to cardiac output, it was lower in females as compared to males by all 3 methods. Looking again at 3D just as an example, we see that the average for females was 4.5 liters per minute, and for males, 5.17 liters per minute. Coming to cardiac index, it was only significantly lower in females by the 2D method only. In fact, if we use 3D as an example again, the cardiac index in females and males was the same value at 2.74 liters per minute per meter squared. Moving forward to comparisons by age, the authors then presented this initially based on gender and then stratified those participants based on age using 3 groups, 18 to 40, 41 to 65, and greater than 65. And you can see that there was a relatively equal number of patients in each of these groups. Some important trends were noted and differences as well. There was a decrease in stroke volume and stroke volume index with age by the 2D and 3D methods. However, there were no significant differences across the spectrum of age when the Doppler technique was used to calculate the stroke volume or stroke volume index. The cardiac output was lower across these age groups, so it decreased over time by all 3 methods. The cardiac index, again, was similar with Doppler, however, decreased as patients were older by the 2D and 3D methods. This then allowed the authors to present lower limits of normal for stroke volume and stroke volume index for men and women based on age and based on measurement technique. Importantly, they indexed for BSA as well as for height. There's a lot of numbers on this slide, but I think in the context of what Dr. D highlighted in the introduction, as well as Dr. Picard, I'll focus your attention on the values for individuals over 65 years of age. The average BSA indexed stroke volume for men over 65 was 24 by Doppler, 20 by 2D echo, and 26 by 3D echo. For women, the numbers were 24 by Doppler, 17 by 2D echo, and 24 by 3D echo. And I think these values are important for us to consider when we think about how we classically define low stroke volume states at present time. Moving forward to comparisons by race, the authors again present this first based on gender and then based on race. There are some, again, important statistical differences to highlight. So firstly, stroke volume and cardiac outputs were smallest in Asians and largest in white participants. If we use 3D echo as an example again, you can see that Asian men had an average stroke volume of 72, whereas white men had an average stroke volume of 88. Looking to the females, the average Asian woman had a stroke volume of 61, rounding up just slightly, and the average white woman had an average stroke volume of 71. However, when these values were indexed, They remained statistically significant, although the absolute difference was attenuated. So if we look at the BSA index stroke volume, as an example, in Asian men, the average was 41, and in white men, 44, and cardiac index 2.7 in Asian men and 2.8 in white men. The last comparison that the authors highlight to us is comparisons between vendors, noting that their analysis was performed using vendor-neutral software. However, the images were acquired on standard imaging platforms, with Philips being the most common and GE the second most common. They did present that there were some differences in non-indexed stroke volume and cardiac output. However, there are no significant differences in the indexed estimates. So to summarize their results, the authors presented 5 important findings for us. Firstly, the reference ranges for cardiac output and stroke volume differed significantly based on the measurement technique. So 2D, 3D, and Doppler were different. 2D assessments yielded lower cardiac output and stroke volume compared with Doppler and 3D. Thirdly, women have smaller cardiac output and stroke volume compared to men, as measured by all 3 methods, despite normalization to BSA. Fourthly, older individuals have smaller stroke volume and stroke volume index based on 2D and 3D, with similar values identified on Doppler. And lastly, race influenced cardiac output and stroke volume, although these differences were attenuated with indexation to BSA. Moving forward to putting these findings into some context, I'll present the points of discussion raised in the paper. So firstly, the authors help us understand how technical differences in these measurement techniques may explain the differences identified in this study. The first, when we compare 2D versus 3D acquisition techniques, we recognize the pitfalls of geometric assumptions for the volumetric calculations from 2D echo, and also that despite our best efforts to standardize apical images, we may not optimize the images for volumes, and that these pitfalls can be overcome with acquisition of a 3D data set. When we are trying to explain the differences between Doppler and 3D, one of the errors that they point out is that in the LVOT stroke volume method with the Doppler technique, we are making assumptions that the LVOT is circular, and our evolving clinical experience and data highlights that it may be more elliptical rather than circular, and this can lead to some underestimation of stroke volume by this technique. There are also pitfalls of 3D to acknowledge. In this study, the authors reported that they had to exclude potential participants that were unable to have a full 3D data set acquired, and obesity is one of the issues that relates to that. And of course, it's very challenging to get a good 3D image if you can't get a good 2D image. So I think this is an important pitfall for us to recognize in our North American contexts. Moving forward, they did point out that although there were statistically significant differences in the Doppler and 3D estimates, these differences are unlikely to have clinical significance. So as a reminder, the index stroke volume on a Doppler was 39 milliliters per meter squared, and on 3D echo, 41 milliliters per meter squared. And the cardiac index was 2.6 from the Doppler method and 2.74 from 3D echo. So I think this is important for us, recognizing that the Doppler method is part of our standard image acquisition protocol. And in many labs, 3D data sets are required in a subset of patients at present time. The next point is about using 2D to check Doppler measurements, which sometimes we do in research settings. This is one example where they talk about using the Doppler echo method for stroke volume and corroborating it with the 2D volumetric method. I think this data challenges us to reconsider using this, given that they did not find that the two techniques were interchangeable. And similarly, we may elect to use the quantitative volumetric method to assess MR severity, subtracting the Doppler stroke volumes from the 2D volumetric stroke volumes to get the regurgitant fraction of mitral regurgitation. And perhaps this needs to be reconsidered because even in individuals with normal hearts, these values may not be the same. Moving forward to some discussion about aging. The decreased stroke volume and cardiac output in older individuals is consistent with many prior studies and is often explained by changes in the left ventricle with aging, including the fact that the LV becomes more elliptical with aging. They also point out that technical differences likely explain the lack of a decrease in stroke volume using Doppler with aging, in that these patients, many of them, develop basal septal hypertrophy, which can result in a skewed flow profile and inaccuracies in the estimates of stroke volume using the Doppler technique. To comment about the differences that they noted in race, the authors emphasize that indexing minimizes the differences between races, and this has been seen in other studies as well, such as the JAMP study. Coming now to some of the clinical applications and these normative values, the study not only further emphasizes that we should be using gender-specific index normative ranges for echo parameters, but also raises the question that we need to have normal ranges based on the technique used to acquire them. And this paper does provide us with normative ranges that can be used clinically, and importantly does index them to height, which is important in our North American context, as alluded to by Dr. Picard in the introduction. The next question that the authors highlight is about the stroke volume index in paradoxical low flow, low gradient aortic stenosis, with the current definition being less than 35 milliliters per meter squared. Recent data has suggested perhaps different cutoffs based on gender, with a cutoff for men being 40 and women being 32. And again, the differences that they saw in stroke volume index between the genders would question us about whether we should be using gender-specific normative ranges for stroke volume index in the definition of paradoxical low flow, low gradient AS. I think this paper also, to me as an echocardiographer, makes me wonder if we should specify the acquisition technique to determine the stroke volume index in this definition. To close with a few limitations, the authors acknowledge that feasibility limits inclusion of all countries and races. However, they did have quite a wide variety of countries participating. There was a focus on unenhanced measurements, and I think in our lab, we're using contrast or an ultrasound enhancing agent in many patients, recognizing that there are also studies showing that its use can improve the reliability and accuracy compared to other methods over just plain 2D echo, and that an ultrasound enhancing agent can also improve the reliability of 3 echo images as well. So that would be something interesting to further explore. And lastly, we have to acknowledge that there are variability in the measurements, including the volumetric and the Doppler methods that are important for us when we consider the statistical and clinical significance of the findings. So I'll summarize the 3 key findings before going to the discussion in the expert panel. So firstly, results provide normal reference ranges for cardiac output and stroke volume, which differ by age, sex, and race. Furthermore, cardiac index and stroke volume measurements by the different measurement techniques are not interchangeable. And lastly, all of these factors need to be considered when evaluating cardiac function and hemodynamics in individual patients.
Well, thank you very much, Dr. D and Dr. Blissett, for giving us a very comprehensive discussion of all the data in this paper. So this time I would like to open the floor for discussion. We've got about 15 minutes for discussion. And as mentioned before, please feel free to enter your questions into the chat box, and I would feed the questions to the expert panelists and the presenters as well. Well, I think perhaps maybe I'll get started. Or to mention that I think Dr. Roberto Lang is in the audience as well. And I think it's fantastic that Dr. Lang is in the audience, that if there's any further insight or answers to questions, feel free to chime in as well. Please, thank you so much, Dr. Lang, for being with us today.
Dr. Lang, you are unmuted, so you can participate whenever you like.
So, well, again, thank you, Dr. D and Dr. Blissett, for discussing the data and maybe highlighting the differences between statistical and clinical significance of the discrepancies found in in the paper. So after all, I think one question that a lot of people or participants in the audience may have in mind is that how will the findings change our practice going forward, particularly given your line of practice, the two of you being in heart failure, managing patients with adult congenital heart disease as well. Is that going to influence you one way or the other going forward?
I think it's, I'll just start, I think it's, you have to kind of put it in the context of contemporary guidelines. And, as they mentioned in the limitations, I think the LVOT stroke volume is our workhorse. It's easy, it's easily accessible, in terms of, 2D is a little more accessible. It is more accessible. 3D is getting there. But I think it's interesting in watching trends on serial studies. If I am looking at a patient who I'm worried about, for instance, a cardiotoxicity patient or somebody who may be at risk of developing a fulminant cardiomyopathy, or if I'm looking for LV remodeling. But at the same time, I think it does make you question how you're going to classify it. So let me put it back with a question on you. So if above the age of 65, the average stroke volume index in a male was a number 20. Was in the 20s, 24, then how are we going to then apply our let's say that if that's normal, and how are we going to do the aortic stenosis subclassification? Are we going to call this paradox? If you have somebody with who had, like the patient I showed in my example, where the stroke volume index is less than 35, that could still be normal. Does that then change the classification? So I think, trends are good. I think it shows us differences across different modalities. But I think, it's going to be business as usual. We're going to apply the ASC guidelines as we do in our lab. And but I think for individual patients, bad ramps in novel situations, as I'm sure applies to Dr. Blissett, that stroke volume index is going to be telling, but we might know how to put it in context now based on the age and unique patient identifiers. So that's kind of, I don't know, Dr. Sarah, do you want to say anything? Or?
Oh, it looks like Dr. Chen Turneau might want to say
Oh,
something,
go ahead,
so I'll let her.
Yeah, sorry, no, I think this is a really important point. So just to clarify that the 24 milliliters for stroke volume index for men above age 65, that's the 2.5th percentile. So that's the lower limit, but it's not the average. So I think it suggests to us that if we're using the cutoff of, for example, 35 milliliters per meter squared, there's probably a large population of patients that do have a lower flow across that aortic valve. And so that sort of correlates with our clinical impression that there are a significant proportion of patients with low flow, low gradient paradoxical severe AS. But another point is just that you're right, the Doppler of the LVOT is our workhorse. It's so convenient, right? You're assessing someone for severe AS and it's right there, and you can kind of compare your pulse wave and your continuous wave Doppler profiles. But this is very eye-opening to me as a clinician to know that that stroke volume index might not be representative of the true stroke volume index in an older patient, who are exactly the types of patients that we are concerned about this physiology. Because I think, as Dr. Blissett alluded to, the truth is probably more represented by the 2D and 3D volumes in older patients. And there are, and perhaps the LVOT is less remodeled with aging, and because of this basal septal hypertrophy, perhaps the flow profile is different as well. And so we're not able to capture the evolution of stroke volume index with that Doppler profile. So it certainly makes me more attuned to the fact that when I see a stenotic looking valve and I think it's severe, but my stroke volume index by Doppler is still above 35, it would make me want to investigate a little bit further. And it certainly highlights the importance of acquiring those 3D full volume acquisitions to be able to do that.
Thank you, everyone. Also, as a follow-up question then, so I think we've got representation from multiple echo labs in the country and in North America as well. So how often are we using 3D for 3D EF or 3D full capture or full volume for stroke volume purposes, or EF estimation then? I will start by saying that I think in Vancouver, I think we try to do as much 3D as possible, just to get the sonographers to be familiar with the technique. But clinically, we haven't really been putting that into very frequent use, though.
Yeah, in Montreal, we really use it in the cardio-oncology population when we follow up LV ejection fraction. But I guess based on these findings, maybe we should be doing it more often.
Yeah, I'll chime in here in London. We, much like Michael had said, we use it where we can. We use a lot of contrast here, and we do use 3D in special populations such as cardio-oncology as well. So it's not prime time, but it is being used a fair bit where possible.
Dr. Sanfilippo, would you like to comment from the Kingston experience?
I think it's the same as what we're hearing from our colleagues in London and Montreal. Certainly the cardio-oncology group, it's becoming sort of standard. We would like folks to do it more just in order to become more comfortable with it, but there's a practical issue with resources and time. So I think that's where we are. Whether we should be doing more or not, I think is an interesting question. The data would suggest that there are, the differences are certainly there and worth quantifying. The question is how they're going to drive clinical practice, and I think the jury's still a bit out on that.
Now, after hearing all the data and the discussion of the paper, so are we going to adopt any changes in ethnic-specific or sex-specific cutoff for our stroke volume index? Any insights on that?
I'll maybe follow up with a question, which is in terms of future research studies, we want to enroll as heterogeneous and broad a population or representative of a population as possible, but then are we going to build in subgroup analyses because of the different cutoffs, or are we then better off enrolling homogeneous populations where we have, good cutoffs? What would be the approach for future research studies now that we have proof or evidence from the WAZE, so many of the studies that have come out of WAZE, that there are important differences both in ethnicity, age, sex?
I think for me, this is showing the greater importance of making sure the populations are not homogeneous, because you cannot extrapolate to different populations, especially if there's significant differences. I think that's a great question, and that should be something that is considered in future studies. So, Sabe, what do you think?
Yeah, I agree. I think to me, it's very hypothesis generating. It does, but I think beyond that, it actually does show that there are differences. And as time goes on in cardiology in general, clinically, we know there are gender differences, ethnic differences as well. I really like the spirit of the WAZE study. I have to commend the authors and the centers that are involved in the enrollment, because it really does sort of take, an echo that's done here in London to maybe one that's done in Chicago, and you have a little bit of a framework as to how to look at it. And it is really hard, I think, not being a huge researcher myself, but I think it is very, very difficult to sort of get homogeneity in your populations wherever you are. So yeah, I think for sure these are things that we're going to have to consider in our lab. I'm gonna, the tables that are here, I like all the ASC tables. They're photocopied all over my desk, the volume ones, who's mildly dilated, who's moderately dilated. And now I've got another one for the stroke volume to look at. So I think it's great data, and where people go with it, really time will tell.
I think there's a question from the audience. I think, Johri?
Yeah, just actually more of a comment. I think to me, I'm a general cardiologist practicing echo, but the standardization for height really moves the goalpost. the amount of unappreciated high output heart failure in obese patients is just gigantic. And, you know, I noticed, Dr. Sang, you're from Vancouver. You don't have the same problem out there that we do. So as you know, the size of patient grades all the way across the country. And I know from living there for a long time, by the time you hit Nova Scotia, Newfoundland, you know, your body mass index is like 32, 34 is a pretty standard number. So, you know, the fact that we can actually get a standard based on height and take out the obesity factor, I think that's the part that needs to move forward in echo reports for the hemodynamic side of it. It's going to be huge in heart failure management.
And to add to that, in the population of pregnant patients, indexing to height is very important, as the weight is changing for reasons other than increase in maternal size over the course of the pregnancy. So indexing to height is a huge advantage in that population as well.
Fantastic. Thank you very much for bringing up the great points. And also in the chat, I think Dr. Howard Liangpoi, thank you for bringing up, Howard, that Dr. Blissett mentioned the use of ultrasound enhancing agent, especially for 2D LV volumes in EF. The use of ultrasound enhancing agent leads to LV volumes that better match with 3D LV volumes. Great point. Thank you.
Looks like Dr. O'Reilly might have raised a hand.
Yep, Dr. O'Reilly asked his question, and we have Dr. Mulvey mentioning that, yes, she agrees with Howard, and her understanding was that the WAZE study was not employing use of contrast, and this population was mostly Asian with lower BMI, so probably wouldn't be used. So perhaps Sarah and Sabe, you guys can comment on that point.
Oh. Yes, thank you. Thank you for raising these points. And yes, there is a study from 2014 by Hoffman et al. That showed the use of an ultrasound enhancing agent did improve the accuracy and reliability of 2D echo volumes, and they were very close to those obtained from 3D echo and enhanced 3D echo as well. And certainly the population that was studied, being 42% were Asian, they may not have needed an ultrasound enhancing agent based on our current clinical use. I think as we try to apply these results to our North American context, that's where we may see some benefit of looking at that. And it would be interesting if any of the authors from the WAZE study have any insights on that based on their analysis of the data.
Thanks for that comment. I think Dr. Lang was online, but he had to step out, and he said that you guys did a fantastic job, were his comments on your presentation. So Dr. Tsang, would you be okay if we sort of begin to wrap up?
Absolutely.
Great.
Yeah, thank you very much for all the presenters, Dr. D and Dr. Blissett, and thank you Dr. Chantanu and Dr. Ben Barkett as well for being our expert panelists today. So I'll hand over to Dr. Johri for the closing remarks.
Yeah, so Dr. Devinder Jasal, who is our CSE president, has joined, and he just wanted to comment that he's thanking everyone as well as JASE colleagues. He wanted to remind us that the CSE Create Research Grant deadline is upcoming for October 1st, 2021. Our annual CSE AGM meeting is scheduled for October 26th. And that's from Dr. Jasal. That comment is in the chat. I also wanted to bring up another point of collaboration. So ASC is having a Twitter journal club on October 12th at 8 p.m. Eastern Standard Time. Dr. Ritu Taman does a wonderful job with that. So keep an eye out on Twitter for that. And, you know, this brings us to our STEAM portion of our podcast, which we've been doing regularly with a JASE podcast. And so this is where we bring in a little bit of art and humanities to our science-based discussion. So this is where I ask our speakers, our guest speakers, to tell us a little bit about themselves. So I'm going to begin with Sarah. Sarah, I want you to tell me about your interest in arts and humanities. So as we end this program on a lighter note, what would you like to share?
Thank you so much for the opportunity. So this is a painting that was gifted to me as a graduation present from my fellowship training. And it means something to me because it represents the work that I did, but also having a chance to talk to the artist and that she really enjoys painting when there's elements of human intervention into the natural world. So this painting is of a grapefruit tree as she saw it through the pane of glass of a greenhouse. And I was so excited to hear that when she mentioned it to me, because it made me think a little bit more about my work and my role as a cardiologist, and how that comment really rings true and resonates with what we do in echo. So sort of bringing it full circle.
Wow, that's amazing. So is this a large painting?
Yes, it is. And it was FedExed from San Francisco.
Wow.
Yeah. Mm-hmm, yeah.
Where do you have it up?
It's in my living room now.
Okay, great. That's wonderful. Thank you for sharing. It's beautiful. And last but not least, Dr. D, what would you like to share? And are we ready for this?
Well, first of all, Amr, thank you for this. I mean, I'm a little bit out of steam, but I'm ready for steam. And everybody knows that, I'm not an artist. I'm a martial artist. Okay. But that being said, in the spirit of your JASE podcast, I do have some pieces of art that I would like to share.
Do we need a warning, a PG warning?
No. This is all very user friendly. So I'm going to give you a little bit of insight into my psyche. Okay, so the first one is probably the most famous piece of Japanese art. I love the country of Japan. The poster hangs up over there, and this is the Waves of Kanagawa. And you can see here that I have socks with this on. I've got a poster with this on. I just like it. You can see Mount Fuji here in the background. There's some boats. This is the most popular piece of Japanese art ever. I kind of like the way it looks. Makes if I'm trying to calculate stroke volume index, chills me out if I look at it. So, then I have to look at the ethnicity, and then I'm like, it's Asian, it's from Japan, which was how WAZE study, Indian people and Japanese people are Asian. So I kind of like it from that standpoint. So I just want to add that this is actually a block print. Yeah, that's right.
So it is famous, as you said, and it's actually a print piece.
Yeah, absolutely. Now, I want to do well for the STEAM portion. Okay, that's really why I showed up today. The paper just got me to the STEAM portion because I think this is where real audience education is important. And the second piece I have, this is called Chop Suey by Ed Hopper. It was done in 1929. And you can see here, it basically shows these two ladies are having a meal together, but they're really lonely in the perils of modern civilization. So maybe it applies to the pandemic, maybe not. Now, let me ask you something, Amr. What do you think this painting sold for?
I don't know, actually. I guess since you're asking me a very high amount.
92 million.
Oh my God, I was gonna say $1 million.
And I want to show you something else, Amr. Take a look at the wall. I will sell it to you for 50 million.
Oh my God, okay. All right. Well, I know that the CREATE grant is coming up, and so if I'm successful, I might be able to look at. I'll ask Dr. Jasal if we can expand our budget. So great. Thank you so much, guys. I really appreciate you doing all this work and bringing in some wonderful color from your paintings and from your personal life into scientific education. I want to thank everyone for joining the JASE podcast. I think this was a very successful collaboration with CSC Virtual Journal Club. And I'm going to be posting this online at the ASE website. And just wanted to let you know that if you want to get into the paper in more depth, it'll be available in the October 2021 issue of the journal. Thanks, everyone. Take care. Bye.
Thank you.